Well, I prepared two speeches today. I prepared the first one, which will be relatively short, talking about technology in response to the discussion going on in Washington, D.C. And then I prepared the second one, talking about enabling technology focused on innovation in healthcare, which is meant for the audience here today. Let me hit the first one. Having been in Washington last week when the president made his address and following up on the dialogue between the Republicans and the Dems and the reformists and the non-reformists, I want to assure both sides that we have all the technology that we need to satisfy the current debate in Washington, D.C. That is, I think it's relatively simple to figure out who is a resident citizen or legally resident visitor to the United States and who's an illegal alien. That seems to be what the debate in Washington, D.C. is about, first and foremost for healthcare reform. That's a trivial technology problem. The second one is, it's also trivial to do what they're talking about doing to reform healthcare. And I like to use the model here kind of between General Motors and the U.S. and healthcare reform. General Motors had about a 20-year history of trying to be successful by squeezing their suppliers to the tune of about 10% a year. Just lower your costs by 10% a year. What I figured out is that's what the government's trying to do with healthcare as well. Let's squeeze the suppliers by 10% a year, and that will be our cost control mechanism. We don't have to reform the system. We don't have to change the delivery mechanism. We don't have to do anything else other than cut the payments to Medicare suppliers by 10% a year. Those are two trivial technology problems. Unfortunately, they're the wrong problems to talk about solving. And as the previous speakers have mentioned, there's plenty of opportunity for real reform in this system. And so I'm going to now switch to the other half of the presentation, which is how can technology help reform medical care? That is, deliver better health care at lower cost, more effectively, more productively. I think that's really what the topic should be discussed in Washington, D.C., but we haven't even come close to that. I'm here for a couple reasons. One is I'm probably older than most of you in the audience. I just got my Medicare card. I'm looking forward to you people supporting my health care. Okay? So I'm part of that older generation. The second reason I'm here is I'm an engineer, and I kind of have no medical background. In deference to Clay Christensen, I've never taken a business school course in my life. But I did work for, I think, a world-leading company, a manufacturing company in the U.S. where we're not supposed to do manufacturing. That was one of the bits of advice we got from the Harvard Business School back in the mid-'80s. Get out of manufacturing. We ignored it. We did okay, and are still doing okay. But if you're an engineer, you are trained in problem solving, and if you look at the two big problems the U.S. has today in terms of its global competitiveness, as elicited in there, announced in the introduction, one is K through 12 education in the United States, which is substandard at best, mediocre at best, needs dramatic reform and improvement. And healthcare is the other one, which is a drag on the competitiveness of the United States. If you don't believe that about healthcare, let me just bore you with some numbers real quick. $2.5 trillion, 300 million people, about $8,000 per person per year is the healthcare cost of the United States. For a family of four, that's $32,000 a year. A company like my own can hire fully loaded an engineer in China or India for less than $32,000 a year. That is less than the healthcare cost of the United States for a family of four. What does that say about competitiveness? It says basically you're not going to have the sort of jobs that an Intel will create in the United States long term because you can't afford to have them here just on the healthcare cost. Everyone has said today that we spend twice as much on healthcare in terms of percentage of GDP as any other Western European country or basically any country in the United States, and we don't get that much for it. So what's the deal? Why do we spend twice as much for the same or less in performance? And what I'll try to talk about today is not so much on education, but on healthcare. How can you use technology to make that better? Now, my biggest message to you is Moore's Law, which has driven our industry, integrated circuit and computer industry, for the last 40 or 50 years, is alive and well. You're going to get twice as much computing power, twice as much memory density, twice as much visualization capability, twice as big databases, et cetera, every 18 months or so for the foreseeable future. So technology is continuing its march ahead. It's going to create some wonderful medical devices. We've all talked about MRIs and CAT scans and PET scans and those sort of things today. We'll give you more and more capability to pursue those. We'll give you the compute power to index your individual genome very inexpensively. We'll give you all that capability. But I don't think that's going to do a darn thing to providing better health care at lower cost. There are things that you have to do to reform the system. Now, from an engineering standpoint, what do I think you have to do? Engineers always look at 80-20. Where does 80% of the cost come from? And usually it comes from 20% or less of what's creating the cost. And healthcare is no different than that. We all know chronically ill, old people like me are most of the cost. So unless you do something about those patients, those recipients of healthcare, you cannot touch the total cost of the system. I could ask how many of you out there think you are average people and in relatively good health, and most of you will put up your hands. And I will say, gee, if we could reduce your healthcare costs by 50% and do that for the entire 80% of people like you in the United States, that 50% reduction, halving your healthcare costs per year, would amount to 1 year of inflation of the healthcare costs in the United States. Just 1 year of the inflation. So after 1 year, all that benefit goes away. The only way you can touch this is to focus on chronically ill people and focus on old people and figure out how technology can provide better service. And all the time when I'm talking, I'll try to put the patient or the consumer in the forefront. Part of the problem we have in the United States, as you well know, is you and I as consumers, and even a company like Intel, which has 50 or 55,000 US employees, as a consumer of healthcare costs, is minuscule in terms of their negotiating power. The government spends 50% of the money, the next person spends less than 1%, and systems only respond to where the money is and where the money is going, unless either all of business combines its effort or the government decides to do something. Nobody's going to move the system. It's just going to continue on its own course. So we'll talk about what sort of things can happen. What are some of the small steps that industry and industry associations are taking? Where's technology coming and going? And I hope that you understand technology is going to continue its march forward. Frank Moss and some of the other people after me today will talk about some of the great new technology aspects. I'll give you a couple of simple little demonstrations of technology. But quite frankly, I don't think we need new technology to get dramatic modification of the system or improvement of the system. A couple of years ago when I was in Kuala Lumpur, Malaysia, and giving a talk for the World Conference on IT, I came back to my room that night, and on my pillow was one of these little thoughts for the day. And I think that thought for the day is entirely germane for this group and for the healthcare debate in the United States. And the thought for the day said very simply, a small deed done is better than a great deed planned. And I really think that what's going to change the system in the United States is not a great plan coming from Washington, D.C. It's going to be a series of small deeds done demonstrating what can happen, sort of things that go on here at Mayo, sort of things that go on at Kaiser Permanente, sort of things that go on at the VA. Those are demonstrations of what can be done. We have to take those demonstration proofs and then replicate them. But they start off with small deeds done, not with a global reorganization of the system. So, we're after change in behavior, personal behavior, organizational behavior. You've heard both of those discussed today. We're after better health, not so much better health care, but better health, because that's what we're really all about, is health and not just health care. And achieving that through a change in behavior, change in responsibility, change in accountability. So, where do you start? By the way, I do stand up here. I am retired from Intel, so I'm not speaking for Intel. I'm speaking for Craig Barrett. But I'll try to draw from the comments of my high-tech background. I want you to also recognize that I'm a rancher in Montana on the side, and I will draw a parallel at the end of the talk in terms of healthcare for a rancher in Montana and healthcare for a big high-tech company. I think I have a very interesting analogy for you, but you have to wait for the end of that. Okay, what do we want to do today? I do not want to talk about balloon squeezing, which is the Washington, D.C. debate. D.C. is a debate of who pays, and anybody who calls that health reform just is totally out of it. The issue is not who pays. The issue is not should we insure the non-insured. The issue is how do you make this system better? How do you give the patient more customized treatment, customer-centric treatment, etc. There's a lot of things that we've demonstrated from a technology standpoint. Denny Cortez mentioned one, which has to do with electronic prescriptions. The fact that 100,000 people in the US each year are killed, maimed, hospitalized, or something by errors in prescription or negative drug-to-drug interactions. 4 years ago, I joined something called AHIC, American Health Information Community. First meeting, I put up my hand. I said, why doesn't CMS dictate that all prescriptions they pay for will be electronic within 12 months? That will make the whole system swing over. We're still waiting for the trials to be run to make sure that that's possible. I've heard every great excuse in the world why you can't have electronic prescriptions in the US. Doctors don't have PCs. Is there a doctor in here who does not have a PC? It interrupts the workflow. One of the tenets of my speech today will be any time you change a system, guess what happens? The workflow gets changed. Every industry in the world, save education and healthcare, have changed their workflow to accommodate technology, to provide better service to their customers. So anytime somebody tells me, I can't possibly type in a prescription, I have to write it out in my illegible handwriting, I just say, come on, be serious. Question for you to think about is how many Chevrolet pickup trucks does it take to be involved in an accident to recall 2 million Chevy pickups? A handful. And as Denny Cortez said, 1.5 747s, equivalent of that crashing every day is equivalent of how many people are injured or impacted by prescriptions. Why don't we just say to the Washington, D.C. folks, get off your duff and let's just have electronic prescriptions across the board? I mean, why is that so difficult? Simple technology, small deed done better than a great deed planned. We also need, as I said, to focus on where the cost is. And so let's start with the 20% of the people who have the majority of the cost. The concept that we are going to create a national health information network, and every one of you is going to have every one of your medical records available to anybody at any time who needs to see them, who you agree to let them see them. How many of you in this audience believe that this is going to happen in your lifetime? I saw 5 hands come up. 6. You're only allowed to put up 1 hand. You know, there are very simple ways to have medical records available to you and to the prescription, to the physicians who are serving you. There's something called the internet. something called a personal site on the internet. It's something called downloading your medical records onto that site, personal, private, portable site, and having it available. Very simple technology. We'll talk a little bit about that as we go forward. The thing I don't like to talk about in this issue is how IT, information technology, is just going to magically make everything better overnight, because it's not. IT is a tool. It's how you use the tool that's important. And we're talking about modifying the system, changing the system. You have to change the system intelligently by using the tool if you want to get a good result. And that's what we've seen in every other industry where people have modified the way they do business. Whether it's banking, whether it's telecom, whether it's manufacturing or retailing. You know, my favorite example of somebody who has used the technology intelligently is Walmart. What is Walmart? Walmart is the world's biggest IT company masquerading as a retailer. The CEO of Walmart gets on his desk every morning the sales results of every store that Walmart has and every line item that Walmart has every night. Wouldn't the head of CDC love to have that capability? Every infectious disease case in the United States on their desk the next morning? What is Walmart's competitive advantage? It's how they intelligently use IT. It's not that they just have bigger stores, more people, more employees. It's that they intelligently use IT for inventory control, pricing control, use it as a competitive advantage. So, IT has been great for every industry except this one, and maybe education. These happen to be two which are predominantly controlled by the government, either local government or national government, and are resistant to change, but it doesn't mean that IT can't be used intelligently. So, how do we start? Let's start by just looking at a quick video which might give us some thoughts.
I think there's pieces coming together that are going to change the game in how we do healthcare. You have these convergent everyday technologies, cell phones, PCs, laptops, all able to interconnect with each other securely and wirelessly.
Once one gets beyond the office visit as a transaction and starts to think about the population of patients and how to manage a population, that helps the capacity challenge.
The long-term care network needs to be redesigned to support people with services they need, when they need them, in a place they call home.
The more we can keep you in your own home where you don't have to make a pilgrimage to the hospital to get care, the more we can detect disease with technologies that are in your everyday life.
We took the current labor force in primary care and asked them to see patients every 2 minutes. We still couldn't meet the needs of the growing chronic illness that we see in the future.
63% of our adults are classified as either overweight or obese. 43% of our school-aged children are either overweight or at risk of being overweight.
Feedback changes behavior, and that feedback comes from various sensors monitoring the physiology.
Blood pressure, glucose monitors, peak flow meters for folks with asthma, weight scales, the opportunities are endless.
Good decision-making in healthcare requires good information. And it requires the information being available when you're making the decision. A biópsia de pele demora 2 meses para receber resultado. Como imagem que eu estou enviando, que eu vi agora hoje, deste sem fio, com esta câmera, o diagnóstico podia ser feito na hora. The real opportunity is that we would strengthen the patient-physician relationship in freeing up the time of the physicians and nurses from the mundane day-to-day duties. They would be able to actually play more of a role in managing complexity.
门诊病人增加了70%，住院病人增加了140%，但是我们的人力资源问题，我们增加是28%。
我们可以收集整个人群的健康信息，然后我们就可以分析出我们当地要采取哪些。
And most important thing
is the patient-doctor relationship. If I can spend less time doing paperwork, but more time interacting with the patient and nurturing the patient-doctor relationship, then I think IT would have done its job.
Now, I apologize for the Chinese and Portuguese in that, but as a company, what a company like Intel has been doing over the last half decade is, in fact, going around the world and seeing how technology can impact healthcare delivery. We do that outside of the United States more than inside the U.S. for the very reason that the governments are much more receptive to it outside the U.S. The example we showed in Portuguese there was on a small island in the middle of the Amazon, Parintins. It's a 24-hour boat ride from Manaus. The most common medical maladies there are, in fact, trauma, motorcycle collisions, and skin lesions. You want to diagnose a skin lesion, cancerous, precancerous, whatever it is. You used to take a skin sample, biopsy, send it by boat off to the hospital in Manaus, take weeks to get a turnaround to find out what to do. High-resolution camera, broadband wireless, satellite link. They do a real-time examination from either Manaus or Sao Paulo to Parintins. People love it. Health providers love it. The government loves it. Compare that to the United States, where unless you're in the doctor's office, you don't get reimbursed. That's why we do things outside the U.S. We can show the technology immediately, show the impact on people's lives, and whether it's in South Africa, Egypt, India, Lebanon, Mexico, Brazil, the technology is being used today in many, many places to its fullest extent. So that's why you saw the translations in there. What does the video say? Video says three things. New care models. It says exactly what Clayton Christensen was showing with his concentric circles this morning. Hospitals are the mainframe of the healthcare industry. And what we need to do is move from hospitals to PCs, or diversified healthcare. And as Clayton mentioned, you can take that from the hospital to the clinic, to the doctor's office, to the home. New care models. And those models will only happen if, in fact, the reimbursement follows along with it. Especially when you get into the home and you start to look at proactive or preventative delivery models as opposed to reactive or hospital-based delivery models. And again, does the workflow change if you move in this direction? Absolutely. Will the system reject or respond negatively to a workflow change? Absolutely. Does the payment structure have to change? Absolutely. And why in the world we can't have that debate in Washington, D.C., I have no idea. The second message is it unburdens the professional. It gets the professional focused on the patient that really needs the service. So the professional has access to the information immediately, not just the last examination, but the patient's history. That's where IT is a great tool. That's where personal health records or electronic health records come into play. The data should be there, right space, right time, in the hands of the people that need it. And we'll just talk about that in just a moment. The third message is you need to empower the patient. And you need to empower the patient because of all the discussion we had this morning, that the system is not patient or consumer friendly, but it should be. And the way we get it that way is, in fact, we start to empower the patient with the ability to manage their own health care. By ability to manage their own health care, I mean they have access to the information about their health care, and then they have all of the other things that the internet provides, which is information about diseases, focus groups, etc. Now, what's a very simple way to start to get uniform access to your healthcare information? Regardless of the 7 of you who raised your hands out there who believe that we are going to have the equivalent of the National Healthcare Service solution in the UK here in the US in your lifetime. You may be much younger than I am. That may be why you voted in that direction. But it's possible today to, in fact, have your own personal health record. And employers are moving in that direction. There are a number of these solutions. One of them happens to be Dossier. Dossier is a consortium of 10 big employers in the U.S., Walmart and healthcare, and Walmart, Intel, AT&T, British Petroleum, Cardinal Healthcare Systems, and a few others. And what we're going to do is we're providing our employees with personal, private, and portable healthcare records as an employee benefit. We, the employer, give this to you, the employee. And what do we give to the employee as a benefit? We give them basically a middleware, a memory space, with an open interface on the bottom and an open interface on the top. And what do those two open interfaces or APIs mean? One of them says the open interface at the bottom is what we talk to all of the healthcare providers about. We want you to be able to upload your information on this patient to their personal website, their personal health record. So there's a standard API, and you just need to configure your system so that you can upload that information into this memory storage space. The open API at the top means any third party can write an application for this. An application which is a wellness application, if you have diabetes, a diabetes monitoring application, a financial system. Any healthcare application in the world can be written to that open API set at the top. So what does the employee have then? He has almost immediately their personal health information, personal, private, and portable. They get to take it with them. Only they see it. Their employer doesn't. Applications that sit on top. They go to another job. We let it go with them. But we give it to our employees as a benefit. This is something you can do today with today's technology and have this done almost overnight. A small deed done rather than a great deed planned. And you can use that information in a variety of ways. You can use it for the individual, for their personal health well-being. In fact, if the employee gives access to third parties like the CDC or such, you can use it to mine the database for infectious disease control and other things. But first and foremost, it's a personal, private, and portable solution. Why are employers doing this? The employers are doing this because basically nobody else is. It's not going to happen in our lifetime. And we have a vested interest, as was mentioned earlier, in our employees' health and providing them with the capability to manage their health going forward. So, the employee owns the data. They can share it with other people if they want, not if they don't want. But the employee acts like a consumer in this case. They use their data to help manage their health capability, their health benefit going forward. That's one bit of a shift to the consumer, to the patient. We also need to shift to where the consumer is and spends most of their time, and that's home or outpatient status. You know, my vision is that the hospital becomes an increasing rare place to go and visit. You heard some discussion earlier about how you could redesign hospitals to make them more efficient, higher productivity, lower cost. I'm all for that. But first and foremost, I think we ought to figure out how not to get people in the hospital. And how do you do that? Well, you monitor them outside of the hospital. You monitor where they live. You have a consumer-centric approach. Now, how does this work? Very simply, it can work in a whole bunch of ways. If you have one of the 5 chronic illnesses that Denny Cortez mentioned, and you can monitor these with blood pressure, blood glucose, your digital weight, et cetera, why don't we just put that capability in the home? Collect that information on a routine basis without having the individual go to a doctor's office, and then monitor that information to see if the patient or the consumer is drifting out of the safe bounds what that metric indicates. How do we keep chronically ill people healthy and out of the hospital, in other words? How do we proactively monitor them? Now, does the federal government, by and large, reimburse for proactive medicine? Does the federal government reimburse for a telephone call? Anybody know when the telephone was invented? Kind of 1875. Don't you think it maybe is about time that we use 140-year-old technology in the delivery of health care and reimburse doctors, physicians for the use of that technology? Forget email, forget the internet. How about just a telephone? So, if we can interconnect health, interconnect it means that gets it out of the hospital, gets it into the home or where the patient is, into the doctor's office, and start to proactively monitor. I think we can do a great deal for the chronically ill and the older people. If you want a simple example of how you might use technology for someone with the onset of Alzheimer's, someone who's suffering from memory loss, put them in home, give them a simple program so when their telephone rings, a screen comes up. It shows who's calling, caller ID, how that person relates to the individual in the home, son, daughter, caregiver, what have you. Gives them a better feeling of independence while they're staying at home. Doesn't put the burden on them if they're having memory loss. Aids them in that respect. Simplest possible technology, available today, can be used. So, you can use cell phones. You can use PCs. You can use any one of a million common technology devices today, and all of them getting better every day to provide better service. So, connectivity, super important. What's happening in the field of connectivity? Broadband wireless is happening more and more, even here in the United States. Broadband wireless or broadband connectivity and monitoring devices can create databases, monitoring databases, to proactively monitor chronically ill people. This doesn't solve all the problem, but in fact, if you can keep a few people out of the hospital by remote monitoring and remote diagnostics, you achieve immense cost savings. You know, there are lots of examples of this stuff that's going on today. And you can't come from a high-tech company and not show a couple examples. Something called Shimmer. Basically, a motion detector with a wireless transmitter. It's kind of neat. You put one of these in each sock and you walk across the stage and somebody can monitor your gait. They can monitor whether you're sitting down or standing up. Very, very simple form of remote monitoring. As you mostly know, falls are a big problem with elderly people. Being able to monitor people, whether they have balance or they don't have balance, whether they're about to fall or not fall, very, very important. Simple technology, form factor is kind of big today, but it's going to shrink down with Moore's Law going forward. We have an outfit called Continua. Continua is a consortium of 200 companies. What is Continua trying to do? Continua is trying to put on a PC, a standard interface, standard communication protocol, and all of the Continua companies are designing remote diagnostic equipment to interface with that. Here I have something called it's a classmate PC. It's a PC designed especially for classroom for young children. Simple to use, small, couple $100. Attached to that, from a wireless standpoint, blood pressure monitor. I can take my blood pressure, wirelessly transmit, store the information, forward that information onward. Ditto with blood glucose, wireless. Ditto with an oximeter, measuring oxygen content, pulse rate. When I climbed Kilimanjaro 2 years ago, I wish I'd had one of those at the top. In fact, you can, communicate from the top of Mount Kilimanjaro to Arusha, the nearest city, and I could have been transmitting information to my doctor and my oxygen level in my blood at the time, using standard technology today. You know, there are other really complicated things you can do. We had a contest for innovations in using technology for remote countries where you don't have the medical expertise in the rural areas that you have in the urban areas. And someone said, well, yeah, I can do this very simply. What they did was they took a cell phone attached here, camera pointing in that direction, microscope column, glass slide. Take a blood sample, insert the slide, take a picture, wirelessly transmit the image, high quality image, to the nearest laboratory that can analyze what you've got. Just a tool, but depending on how you use the tool, depends on the results you get. Simple, standard, off-the-shelf technology to use cell phones, which now are pretty ubiquitous. There are more cell phones in Africa today than there are in the US, if you think Africa is still the dark continent. But you can use any of those cell phones to do this sort of capability. There are lots of other examples, and I say some of the speakers following me will give you more examples, but that's standard off-the-shelf technology. Continua has 200 companies involved. That means at least a couple of hundred medical devices coming out, which will be plug and play, wired or wireless, which will capture information, store it, forward it. Third party can decide, or you can decide if you're a knowledgeable patient, whether you're drifting out of control or not. This is how we're going to control people with chronic illness and people who are in the advanced stages of their life. Well, how do you prove out these new models? When I was on AHIC, one of the things I got most frustrated with was I knew all this technology was here. It was available today, like electronic prescriptions, but how do you get it integrated into the system? And there's some pretty interesting studies going on. The Irish happen to be very, very advanced in the study of aging and remote monitoring and remote diagnostics and reaching out to their population as it ages. They have one of the largest research programs in the world on aging and remote measuring of people so that people can have independent living, staying in their home. The Oregon Health and Science University, similar program, aging research. What technologies can be used for the advanced population? How do you allow people the dignity of living in their home and still provide them with good health care and such? The VA, as many of you know, probably has one of the most extensive measurements of kind of telemedicine, monitoring 17,000 patients and monitoring them with chronic illness to see what sort of improvement they could get in healthcare delivery, healthcare cost, patient benefit. Out of their 17,000 patients, 25% reduction in the number of bed day care units delivered, 19% reduction in hospital admissions. How much did it cost? It cost about $1,500 a year to, in fact, instrument the patient's house for this capability to remotely monitor the patients. Compare the $1,500 a year to 1 day in the hospital. It's one of the reasons that the VA has been able to keep their healthcare costs basically flat over the last several years. Interestingly, if you go to HHS and point out the VA study, they will tell you it's interesting, but it doesn't relate to us because our patient constituency looks different than the VA. I thought the two organizations worked for the same government, but apparently that's not the case. Kaiser, similar deal, congestive heart failure, remote monitoring, standard off-the-shelf technology, basically telemedicine, 21% reduction in mortality for their CHF patients. You know, I think these are good things. Better service to the individual, better health care in their home. Let's take a quick look at another video.
We have an enormous challenge. Today we have about 45 million Medicare beneficiaries. That number over the next decade will grow to more than 70 million. In order to make the system affordable, to provide the right care to these patients in the right setting, we have to become much more effective and efficient. Technology has to play a role to help our reach, our efficiency, and frankly, to help improve outcomes, because you can't physically see every individual every day.
The patients that are involved in this program range anywhere from early 50s all the way up to late 80s. And they've all been diagnosed with congestive heart failure. Most acute patients, critically ill patients, need extra TLC, if you will.
My concerns with Ron's health is overwhelming. There's a lot of anxiety, scary, not knowing from day to day how he will be.
I have a care manager who pretty much checks my daily weight and blood pressure. And Judith is a very, very good friend. Before I got the Intel guide, I had to take my own blood pressure, and it would come up with ridiculously high numbers. I would get this anxious feeling, and the anxious feeling would just raise the blood pressure even more. And now I don't have that problem anymore. I take my blood pressure, Judith checks it, she's happy with it, I'm happy with it, and we just move on. Thank you. It's a great feeling.
You know, our company got involved in digital healthcare a little bit ago, and this is the health guide that was shown in that last video. Basically, it's a PC in disguise with a simple user interface, and the sort of remote diagnostics, blood pressure, or glucometer, whatever can attach to this thing. And it's really difficult to use. It's got big print, so I don't even have to put my reading glasses on. It says, take a measurement, and it says blood pressure, and basically shows me how to do blood pressure measurement. Equipment's right here. Video camera involved, very similar to the video that you showed up there. But this is the sort of remote diagnostics, remote capability I'm talking about that needs to be out of the hospital, even out of the doctor's office, in the home, and needs reimbursement consistent with its usage and its value. As previous speakers have said, pay for value, pay for capability. This is what we're talking about. And now this system, if you just see it from the patient side, you know, it's very convenient. I don't have to go to the doctor's office. I can get my blood pressure, whatever else done on this. But from the caregiver side, there's an entirely different perspective, which is, in fact, what you want to do now is to focus on the patients who are the outliers. You don't want to focus on the patients who are healthy. So, in fact, if this information is gathered, you know, there's my pulse, 72, blood pressure up there. What happens next? It gets put in my database. Some third-party caregiver is reviewing my database, and that caregiver is looking for information which is out of spec, out of normality. And then those are the people you respond to. So whether you're tracking digital weight, blood glucose, blood pressure, all of those things which tend to indicate when a person is getting out of sync with their healthcare regimen and perhaps getting ill and ready to go to the hospital, you want to catch that proactively. This is the sort of system that can do that. Simple, straightforward, a little bit of compute power, a little bit of connectivity, a little bit of easy to use interface, but standard technology which can be applied today. These are the sort of things that I think need your grassroots support. Basic technology applied to today's problem, and specifically applied to that fraction of the population which constitutes the bulk of the healthcare cost going forward. So it needs grassroots leadership from you and from us. It's not going to get it, I'm afraid, from Washington, D.C., because these are not the sort of problems they're addressing there. What happens next? I've talked a little bit about healthcare as a #1 issue in the United States, along with education. From a cost standpoint, it's making us uncompetitive. The debate in Washington, D.C. is not about quality of healthcare. It's not about cost of healthcare per se. It's about covering more people and about who pays. How do you squeeze the balloon to make sure that you have enough money that everybody plays? It's obviously a big, complex problem. I mean, 16 or 70% of the GDP of the United States. Every constituent in the system proclaims their distaste for the system, but every one of them knows exactly where their role is in the current system, and every one of them doesn't want it to change because their role may change. And guess what? You can't change the system unless you change the roles. And I think that this is the basic problem that we have. Nobody wants the system to change because everyone has learned to live within the current system. And the people that really want it to change have no voting power. That's us, the consumer, the patient. We don't have a say. We either take the insurance program we get from our employer, or on Medicare, or on some other program, but as an individual, you have no voting power. So somehow we have to turn that on its head to get a system which values performance, values contribution add to it. And that's totally different from what we have today. Now, the stimulus package has some money in it. It's going to fund the first phase of National Health Information Network. It's going to fund the first phase of electronic health records. But you know, that's a short-term funding deal. That money is going to run out really fast, and people are going to have to figure out how to use that technology effectively to continue to make those investments and to get any return from those investments. I hope that the stimulus money starts to move us in this direction. But unfortunately, I'm not seeing the corresponding shift also in the reimbursement policy going forward. It is pretty clear that long-term, if you invest in IT, you're going to be in a leadership position in this phase. A little bit like Mayo has invested in their IT infrastructure. Even though, Denny, I must admit, I hate to fill out that 5-page form when I go to Mayo Clinic for my physical exam each year. If you guys can do something with that, I would really appreciate it. Let me finish up very simply. Somebody showed the Nike logo in one of their previous presentations. Just do it. Every study I've seen, whether it's the VA or Kaiser, Intermountain, any of these that have some form of integrated healthcare delivery, Mayo, shows the value and the cost and service benefits associated with it. Yet we still, as a country, struggle with how do we reimburse, how do we have the right financial reimbursement model to get the behavior that we want that shows that it works. The government needs to move here. The other 50% of the payer, the employers, need to move as well. And that's why you see companies like Intel and Cisco getting together in Silicon Valley promoting new schemes. That's why you see us putting in clinics and wellness programs amongst our employees. That's why you see us giving the personal health records to our employees. We don't see the system providing that. We have to move forward. We've decided already that status quo is unacceptable. I think you heard a passionate plea from Denny Cortez earlier that the system needs to change. It has to pay for value or the value creators will disappear. The system has to change. Status quo is unacceptable. We have to move from a reactive healthcare system to a proactive. You know, that's a great cliche, but it is exactly what we need. We need wellness and health programs. We don't need healthcare programs. So, let me leave you with the following thought. Technology is a tool. There's a lot of technology available. It's being used by every other industry. Moore's Law is not slowing down. You're going to get more technology, basically double the capability every 18 to 24 months. The question to you all is, how do you use that technology as a tool to change your delivery mechanics such that you can perhaps deal with 50% or 100% more patient interactions at the same cost, at the same footprint, the same staffing level? We're seeing this happen around the world. If you go to Singapore, you see it happen. You see it happen in some of the Chinese hospitals. You see it happen in some of the good hospitals and hospital systems here in the US. But it needs to be pervasive. So the question is, How are you enabling change? How are you using that technology as a tool to move forward? Now, I promised you a story about Montana ranching. I went from CEO of Intel, 55,000 employees in the US, $10,000 or $11,000 a year per employee for healthcare. I've got a small guest ranch in Montana, 45 employees. The healthcare costs for my employees in Montana cost roughly $500 a year per employee. They all have electronic health records. The doctor pays house calls to all their employees. And the employee base includes not just active employees, but also retirees. What's the difference? The Montana employees have 4 legs. They're horses. The problem I have is our horses in Montana, I think, get a better integrated health service delivery than the 55,000 employees with 2 legs we have working at Intel Corporation. Thank you for your time.